Let's learn about open fractures today. An open fracture is a fracture in which the hematoma of the fracture is drained outside through a skin wound. So there is a wound due to disruption of skin and subcutaneous tissue, and the hematoma has drained. This causes exposure of the fracture hematoma to the external environment. Also, devitalization of tissues around the fracture increase the susceptibility to infection. There will be also loss of function because of damage to the tendons, nerves, muscles, or vessels. What is the mechanism of injury? These injuries occur usually due to a high velocity trauma. For example, a road traffic accident, a fall from height, or industrial accidents. The classification for open fractures is Gustilo-Anderson classification. The Gustilo-Anderson classification is divided into type 1, type 2, and type 3 fractures. The type 3 fracture is further subdivided into 3A, 3B, and 3C type. Gustilo-Anderson type 1 fractures have a less than 1 centimeter wound, and the fracture can be transverse or short oblique. These fractures have a clean wound. Type 2 fractures are also transverse or short oblique fractures, which are subtypes of low velocity fractures, and they are associated with more than 1 centimeter wound which does not show extensive soft tissue damage, and the periosteum is intact. In type 3 fractures, these are usually high velocity injuries, and the fractures seen are usually comminuted. The fractures can also be simple type. The peculiar features are that they have more than around 10 centimeter wounds which show extensive damage to the soft tissues with either skin flaps or avulsions. These fractures are further subdivided into type 3A, 3B, and 3C. In type 3A fractures, adequate soft tissue covering is still present as the periosteum is intact here also. These can show high velocity type of fractures like segmental fractures, and example of gunshot injuries also come in these fractures. Type 3B fractures are the fractures where the bone is exposed extensively and the periosteum is not intact and damaged. The fractures with massive contamination also come under 3B. Type 3C fractures are fractures of high velocity with extensive soft tissue component associated with a vascular injury which requires repair. For management of these injuries in the emergency room, first we should stop the bleeding, and the best way to stop bleeding is by direct pressure and not by applying a tourniquet. The most important management in the emergency room is antibiotics. The antibiotics given in emergency room early have been associated with good outcomes in these patients, and a proper splintage should be given to the patient so that the limb gets stabilized and it does not dangle due to the fracture. Along with antibiotics, tetanus immunization should also be given, and finally the x-rays should be performed and the patient should be assessed and prepared for operative intervention. In the OT, first the wound should be extended, followed by copious irrigation of the wound by normal saline. This irrigation will remove a lot of necrotic tissue, debris, and foreign bodies from the wound. Removal of foreign bodies should be done manually, and the wound should be debrided adequately to remove the necrotic tissue and the devitalized structures. In the next step, external fixator should be applied to the bone so that it stabilizes the fracture and the limb, and it will help in dressings in the post-operative period, and it will help in early mobilization of the patient. In grade 3, B or C injuries, the question between amputation versus limb salvage can be solved by calculating the mangled extremity severity score, which can help in determining whether an amputation should be considered in the patient or we should go for a limb salvage surgery. The outcome of the open fractures have a lot of complications. The most common is infection of the bone, which will cause osteomyelitis in the long run, and non-union of the bone because the fracture hematoma is drained and the surrounding tissues are devitalized.